This video will be a brief overview of shock to go along with the pathophysiology chapter of our textbook. When I look at shock, or when I think about shock, I consider or think there are 5 main types. There's really only 3 in the great scheme of things. We break it into 5 categories. To start with, we're going to have hypovolemic, cardiogenic, then distributive, obstructive, and respiratory. I kind of look at this as 3 things. We can have a problem with the pump, so our heart may not work well. Of course, we have pipes that also come off of it. So if there's a problem with the pipes, then there's a problem with it. So maybe it could be a problem with the heart, and the heart, maybe part of the heart's not working well. Could be a problem with the pipe, and that maybe the pipe has a valve in it that's blocked, so it won't go. Or you could maybe have a cut in it, and you could be spilling out all sorts of drops of blood coming out of it. And then, so really I think if there's a problem with the pump, the pipes, or the fluid. And the pump obviously is the heart, the pipes are our blood vessels, and the fluid is the blood. So a problem with the fluid would be hypovolemic shock. A problem with the pump would be cardiogenic shock. Remember, cardio meaning heart. And then a problem with the pipes would be distributive shock. Obstructive shock and respiratory shock are a couple other ones I'll explain in a minute. That kind of tie in, but they're not one of the 3 pump, pipe, or fluid problems. So hypovolemic shock, there's 2 types here. We can have blood loss, which is hemorrhagic, or we can have non-hemorrhagic, which is usually considered like plasma loss, or could be dehydration. So if you have a real hot day and you're out working hard in the yard and not drinking anything, you become dehydrated, and that's also non-hemorrhagic shock. Both of these will lead to a drop in perfusion and drop in blood pressure. When we see signs and symptoms of this, it's the typical shock. And this is the shock that most of us, if we think shock, this is what we're thinking of. And that's going to be things like anxiety, restlessness, fast heart rate, tachycardia, tachypnea, pale, cool, clammy skin, narrowing pulse pressure, all trying to compensate for the blood loss. Non-hemorrhagic shock, things like dehydration, nausea, vomiting, especially a lot of diarrhea, somebody just being sick, and fever and temperature, all that leads to a version of dehydration. When we're looking at signs or symptoms, we may see the ones like you would with hemorrhagic shock, as far as things like tachycardia, tachypnea, anxiousness, restlessness, anxiety, narrowing pulse pressure, and then ultimately last sign is dropping pulse pressure, or dropping blood pressure, falling blood pressure, and that's when we're getting into decompensated shock. In addition to those, you may see things like sunken eyes, dry skin, decreased urine output, for babies and small children, you're going to have sunken fontanelles. So all other things that can go along with sort of a dehydration. I guess the good news is hemorrhagic shock, while it could be very life-threatening, needs to be fixed now, which is generally controlling the bleeding and transport to a surgeon. Non-hemorrhagic usually is not going to kill them right now. We got a little bit of time to get them to the hospital and get them rehydrated. Then we also have cardiogenic shock, which can be broken down into rate problems or myocardial strength. I can hit 170, 180, something like that. And I'm not too worried about that. That's just normal. In fact, we call that sinus tachycardia. But there's also a heart problem that can occur when you get, it's called a re-entry pathway, and you don't need to know that so much, but I want you to understand that when you have your heart, your normal SA node firing here, electrical signal comes down and then it splits to the left and right ventricle. But if you have an extra wire, an extra pathway, it may come back around a second time. So now we can start seeing heart rates of like 180 to 240. And we usually call that SVT, which is supraventricular tachycardia. And now the heart is filling up, the heart is beating so quickly that it can't fill up. So our stroke volume, in this case, goes way down. So if the normal is 70, now because it's beating 3 or 4 times a second, maybe we go from 70 milliliters all the way down to like, let's say 30 milliliters or even less. So you can go too fast. And if you remember the formula, cardiac output equals heart rate multiplied by stroke volume. This is really affecting the stroke volume side of things. Now we can also have a heart rate problem. Maybe your heartbeat was only like, 30. So if that goes way down, then of course cardiac output goes way down. So heart rate can be too low. The ultimate would be is what happens if your heart rate is 0. And then you have no cardiac output, so that would be death, and then we're doing CPR. So too fast, not enough time for heart to fill. Too slow, it's just not beating fast enough to pump the blood around. Another problem we can have is a problem with the myocardial strength. So if we have our heart, and I know I'm not the best drawer of hearts, but you kind of get the idea of the four chambers. And remember, each chamber has a muscle. It's called the myocardium, which is where we get myocardial infarction from. So if that muscle gets weak, you have a heart attack, a myocardial infarction, and part of it dies, and maybe this part here just doesn't beat well anymore. Now my heart just doesn't have the contractility it needs. So if we remember stroke volume, was dependent on 3 things. The preload, which is the amount of blood coming back, and that's actually a problem with like hemorrhagic and non-hemorrhagic shock. Hypovolemic shock, we reduce our preload. We also have a problem with contractility, which is what we're dealing with here, the myocardial strength. And then we also have a problem with afterload. So right now we're dealing with the contractility part of it. So cardiac output equals heart rate multiplied by stroke volume. So now if my contractility is going down, my stroke volume is going down. If my stroke volume goes down, my cardiac output goes down, and then I end up with shock. Distributive shock. There's probably more than just 3 types of distributive shock, but all of these run into a pipe problem. In essence, what happens with this problem is we have our blood vessel, and then something happens and it causes our blood vessel to get much bigger. And obviously, if it was full of blood here, and then we try to take that same amount of blood here, we just can't fill up the blood vessel, and we kind of lose the prime, if you're familiar with plumbing, but there's just not enough blood to fill up the containers. So normally if we have 5 liters of blood, we should have 5 liters of pipe. But when we get into distributive shock, we still have 5 liters of blood, but now we may have something like 9 liters or 10 liters of pipe, and it's just not enough to fill up anymore. Cardiogenic shock. Our body, and I'm just going to do a little stick figure, has a sympathetic and a parasympathetic nervous system. So I'm just going to take the heart out of the body, put it over here for right now. And remember, we have the SA node, the AV node, and then the Purkinje fibers. Well, off of the sympathetic nervous system that comes off the spinal cord, we have a nerve that runs to the SA node and the AV node. And they help to speed things up. So remember, sympathetic is our fight or flight. So that's going to kind of increase the heart rate. But then we also have parasympathetic. And that is our feed and breed. And that helps to slow things down. So, and this also comes off to, actually I think to all three. I'll have to go back and check on that. But anyways, it comes off. So you notice you have both sympathetic and parasympathetic nervous system controlling the AV node and the SA node. And it's kind of like driving with your foot on the brake and on the accelerator. So if something happens and the spinal cord gets damaged, say we cut it or we damage it right up here, and now it's not working, obviously, then the parasympathetic will take over, and that would cause the heart rate to slow down. So some sort of damage to the spinal cord is neurogenic shock. Now the thing that's different with neurogenic shock, yes, the blood pressure will be going down. So we'll see the blood pressure go down. But the thing that is different in this is the heart rate will also go down. And then the skin above the level of the injury will be warm and dry. Will be cool and clammy, but below the level of the injury will be warm and dry. So if this was an injury at about the neck level, then his chest and his abdomen would be warm and dry, where his neck and his face might be cool and clammy, because we don't have the control of the blood vessels below it. So the big thing with this one is I may have somebody in shock, but we'll see the low blood pressure, and normally the heart rate goes up, but in this case the heart rate goes down. Anaphylactic shock. One thing to look for here, and that's part of our history or even part of our assessment, that's angioedema. And that is facial swelling, especially the tongue and throat. And you'll hear their breathing will oftentimes be stridorous. When you listen to their breathing, you'll hear this. It's sort of a... and that's called stridor. Almost always this is going to be 5, 10, 15, maybe 30 minutes after exposure to something. So they ate a peanut they weren't supposed to, or they were stung by a fire ant or a wasp or something. So when we see anaphylactic shock, we see facial swelling. It's one of the classic signs. And that's a big concern because the airway can swell shut completely and then they stop breathing and then they die. We also see hypotension or low blood pressure. And that's the second one. And this, again, remember, all the blood vessels become much larger and can't fill up anymore. And the third thing that we see is usually nausea, vomiting, or abdominal problems. And there may be diarrhea with it, nausea, vomiting, diarrhea. But anyways, abdominal component. Those are the three things that go wrong with anaphylaxis. In fact, we have a whole chapter on this. But, you've probably been bitten or stung by something and had a red spot appear where you were stung. Locally, your blood vessels dilate to try to fight off the toxin that was put in there when you were stung. Anaphylaxis is an overreaction, so instead of it happening just, let's say you got stung in your hand, so instead of just your hand swelling, your entire body will swell, or all the blood vessels will dilate. It can also lead to a rash called urticaria, or hives. And you see that on the torso most often to start with. But you're looking for facial swelling, hypotension, nausea, vomiting, diarrhea after being exposed to something. That's anaphylactic shock. Good news is, as EMTs, you can help them with their EpiPen and hopefully fix it. Now, septic shock. This shock is due to certain types of bacteria, and they either are releasing a toxin, or when our immune system destroys them, they release a toxin. And that's usually called an endotoxin. causes this. And again, our blood vessels here, and they go to here to try to rush more blood, more white blood cells, more nutrients to the area to fight off the infection. So if you have maybe an infection that's on your skin, on your leg, it's going to turn red, and that's because you vasodilate. Your blood vessels dilate, meaning they get bigger. Remember, all of your arterioles have a smooth muscle around them, and alpha 1 and alpha 2 help regulate how constricted and dilated those are, along with your sympathetic and parasympathetic nervous system. So locally, your body's trying to fight off the infection. So if you have a cut on your leg, it turns red, it swells a little bit, it might be a little tender to the touch. And then you might start, if it's not cured, not fixed, you don't fight off the infection, you start to see the streaks, and that's the infection is now getting into the bloodstream and starting to move into the rest of the body. And if it gets into the body and there's enough of an infection, again, all of the blood vessels in the body dilate at once to try to rush more blood there, but you don't have enough blood to fill up all of your blood vessels when they're fully dilated. The thing that's different here, because we may see tachycardia, we may see tachypnea, but we're going to have hot, dry skin or warm, dry skin. And that's the infection. So if you feel someone that has an infection, they usually have a fever, they feel kind of warm, they look flushed, and that's going to be a different sign for this shock. So they might be change in mental status, even unresponsive, heart rate's up, respiratory rate's up, and if they were in hemorrhagic shock, they would have pale, cool, clammy skin, but in this case they're in septic shock, so they have hot, dry skin. That's the sign that you're looking for here. Obstructive shock. 3 big ones with this: tension pneumothorax, cardiac tamponade, and pulmonary embolism. With a tension pneumothorax, you have your chest, and then you have your diaphragm that comes on the bottom of it, and you have a lung on each side. And remember that lung has a lining that runs on the outside of the lining, and there's another lining, a second lining, on the inside of the rib cage. So there's a little bit of space there. So that space between them we call the pleural space. So if we have a hole that appears in one of our chests, we can now begin to get air in there. So every time I take a breath in, air will get sucked in that way. Now this will begin to fill up this pleural space, and eventually it'll fill up more of it, and more of it, and more of it. And now our lung is only going to be that big because all the rest of it is filled up with air. And that would be a pneumothorax. Now a tension pneumo, by the way, pneumo is air, thorax is chest. We have a tension pneumothorax when we have signs of shock. And remember, signs of shock are going to be things like decreasing blood pressure, increasing heart rate. Pale, cool, clammy skin, anxiousness, restlessness, narrowing pulse pressure, and eventually dropping blood pressure. So the way to fix this is to get the air back out of there. Now we also could have air coming in through the trachea and the bronchus and then get into the lungs, and for whatever reason a spot on the lung pops, and now we have a hole in the lung, and then the air can rush out of that. So then it comes out here and then begins to fill up the pleural space and eventually fills up all that space. And then the lung is small again. We have a collapsed lung or a tension pneumothorax. You will have, depending on which side this is on, if this had been, let's say, on the right side, if you listen to the lung sounds on the right, you will have diminished breath sounds. So you won't be able to hear the lung sounds as well there. And the blood that's coming down back to the heart, which is going to be our superior vena cava blood, or in this case, it's going to be our jugular vein. Up there in the neck, you'll see that jugular vein bulging out. It's kind of cool to see when you get to see it. Cardiac tamponade, similar to a tension pneumothorax, but it happens with the heart. So you have your heart, but you also have a lining called the pericardial sac or the pericardium around the heart. And it's just a piece of cellophane on the outside of the heart, but it's very tough, it's very fibrous, and there's a little bit of fluid in there, a little bit of oil, so the heart beats in your chest and you don't feel it move. But if you start to get blood filling up in that space, it will not expand out, but will continue to push in. And then as this fills up with blood and we get this pressure in, now start pushing on the ventricles, filling that up, and then maybe it's going to push in some more, and eventually it kind of fills up the whole space and the heart can't refill with blood, which reduces the amount of stroke volume. Now with the signs of this, again, you're going to have the JVD, the jugular vein distension. You're going to have what they call muffled heart tone. So when you listen to the heart, it's going to sound kind of distant or far away. I'll be honest, that's kind of hard to hear. You're going to have a narrowing pulse pressure, but you should have that on many types of shock. And and all that's called Beck's triad, by the way. But then you're also going to have clear bilateral breath sounds. And the reason that's important is this looks a little bit like a tension pneumothorax, but if you listen to both sides of the chest, you'll be able to hear both lungs, so you know it's not a tension pneumothorax. The last type of obstructive shock is a pulmonary embolism. So again, I'm not the best drawer here, but we'll pretend this is our chest, and we got our diaphragm, got our lungs sitting in here, and we have our heart right in the middle, well, a little bit on the left side. But we know that there's circulation that goes to each of the lungs, and then we also have the pulmonary vein that comes back. And really, I kind of drew the colors backwards. The pulmonary artery should be blue, and the pulmonary vein should be red. Remember, pulmonary circulation is backwards. But in the heart, this branches and goes to different parts, and then these all branch off. But what happens if you were to have a clot form right here? Well, that's I'm going to take that one away. I'm going to say, what if you have a clot form right there, a little bit further down in the bloodstream? Then everything distal to that, further away, will begin to die. So that's a small pulmonary embolism. But if it had happened up here at the beginning, well, then the whole lung doesn't work. But that blocks so much blood now because it's such a big clot that it is obstructing the blood flow, and we get an obstructive shock. So those are the basic types of shock. I could add one more, which is called respiratory. And I don't really think of this as a type of shock, but this would be if you stop breathing. Remember, shock is hypoperfusion, so we have low blood flow. We could also look at this as decreased glucose and decreased oxygen. So the decreased oxygen part is where we get respiratory shock. Again, in my mind, I don't know if I really think of that as a shock, but if you choke on something, they consider it respiratory shock. Now, what happens when we go into shock? Remember, we have our systolic and our diastolic blood pressure. So systolic blood pressure initially is going to start to go up as we start to compensate, and then eventually it's not going to be able to keep up with things anymore, and it's going to start to go down. Our diastolic will do the same thing, but it's going to go down lesser. So we're going to have a narrowing pulse pressure. And the systolic, remember, that's our ventricles. How strong our ventricles are contracting, or how much blood flow is coming out of that. We can kind of think of that maybe as cardiac output. And then we have our diastolic, which is systemic vascular resistance. which is a measure of how normal, constricted, or dilated our blood vessels are. So normally our peripheral blood vessels, the ones in our skins and small muscles and things that we don't really need, so arms and legs, will start to get narrow and constricted. So our systemic vascular resistance actually starts to go up a little bit, and then as our blood pressure drops. Now, as long as we keep a blood pressure greater than 90 systolic, so I'm going to write that as SBP, systolic blood pressure greater than 90, we consider it compensated. When our systolic blood pressure gets below 90, we call it decompensated or uncompensated. That means that all the things the body's trying to do to maintain perfusion, the vasoconstriction and the increased heart rate and the increased respiratory rate and the reduction in urine production, and so we have less urine output, and all the things it's trying to do to keep the blood in the body are failing. So decompensated shock is really a late sign of shock, and that should be a huge warning sign that our patient is about to crash and die. Hope this helped. If you have any questions, please ask me in class. Thank you.